Future Pulse, investigating innovative cardiovascular research and the intersection of academic theory and clinical practice. I'm Dr. Thomas Nero, interventional cardiologist and Director of Cardiovascular Research at CAFC.
Dr. Paul Ridker is the Eugene Brunwell Professor of Medicine at Harvard University and Brigham and Women's Hospital, and he directs the Center for Cardiovascular Disease Prevention. Dr. Ridker also holds an appointment as professor in the Department of Epidemiology at the Harvard T.H. Chan School of Public Health. He's been at the vanguard of the development of inflammation in the diagnosis and treatment of cardiovascular disease. Dr. Ridker developed and proved the utility of high-sensitivity C-reactive protein as one of the most widely used cardiovascular markers, and has been intimately involved in the development of molecules to treat coronary artery disease and to improve outcomes. Thank you so much for joining us today, Dr. Ridker.
It's a pleasure to be here with you.
Today, I wanted to discuss your recently published report in the Lancet on high-sensitivity CRP and residual risk, which I believe will be seen as one of the pivotal papers in the field. But before we get there, can you briefly discuss how your early research got us to where we are today?
Sure. Actually, Tom, in order to understand the new paper, you're absolutely right. We've got to start with where we were in the past. It's quite remarkable at one level. Almost 25, nearly 30 years ago, we made a fundamental observation about atherosclerotic disease, which was that almost half of the patients who would eventually go on to have a heart attack or a stroke actually did not have high cholesterol levels. And on top of that, because of some biology we were doing and some biology that other people were interested in, we made the observation that you could predict, using a simple biomarker of inflammation, who was also at risk for a heart attack or stroke. And that biomarker, as you correctly pointed out, what people now call high-sensitivity C-reactive protein, CRP simply being a downstream acute phase reactant put out by the liver in response to upstream activation in a very specific biologic pathway we'll come back to a little bit later. The key issue was that when you measure inflammation, you augment the problem that cholesterol causes us for future heart attacks and strokes. And over the years, we would show that almost everybody has this inflammatory process, that this inflammation adds to risk the same way that HDL cholesterol or LDL or blood pressure adds to risk, but it was really picking up a very different piece of the biology. Anyway, the fundamental observation we made early on was that inflammation and hyperlipidemia contribute roughly equally to the risk for future heart attack. And as you're well aware, we would show in the ensuing years that statins, the most important drug we have past diet, exercise, and smoking cessation for our patients, the most important prescription drug we have, are lipid-lowering and anti-inflammatory drugs. And so we said, well, okay, here it is nearly 30 years later. What's the relationship now between what we call residual inflammatory risk and residual cholesterol risk? And has it changed since the work that was done some 25, 30 years ago?
Your paper, which was recently highlighted at the ACC, demonstrated that baseline and residual high-sensitivity CRP risk was important, but only the baseline LDL risk.
So the paper itself is actually quite an interesting story, really. Because I was interested in the idea about what's different today than it would be 30 years ago, on the assumption that today, virtually every patient who has chronic atherosclerotic disease is going to be on a statin, assuming they tolerate the drugs. And the vast majority of patients do. And in fact, in my clinic, I'm sure in yours, they're almost all on high-intensity statins. So we had just finished another clinical trial called Prominent. And so I had about 10,000 patients worth of data sitting in my shop where I could ask this question internally. And my hypothesis going in was that in 2023, in a contemporary, aggressive, guideline-directed medical care setting with everybody receiving a high-intensity statin, that maybe the CRP would be similar again to the LDL, because that's what we thought 30 years ago in patients in primary prevention who weren't being treated. And you got to remember, statins lower both LDL and they lower CRP. Well, in Prominent, the first study we looked at, we got a surprising result. And that was that the C-reactive protein, what we call residual inflammatory risk, the risk after taking a statin, was actually quite a strong predictor of recurrent events and a very strong predictor of cardiovascular death and all-cause mortality. But to my surprise, LDL cholesterol really wasn't. And the reason I say to my surprise is because we all understand we have many clinical trials showing us that additional LDL lowering beyond statins does lower cardiovascular risk. So why wasn't this biomarker telling us about the risk? Well, Tom, one of the things a careful investigator does is doesn't go and publish until you really are certain you got it right. So the next step was to call up some friends because I said, I need external validation of this. So I called up Deepak Bhatt, who had been the principal investigator of the REDUCE-IT trial, called up Steve Nissen, the Cleveland Clinic, who had been the principal investigator of the STRENGTH trial. And remember, all three of these studies have in common that they're very contemporary, very aggressively treated, each about 10,000 patients. And none of them were focused on either LDL lowering or CRP lowering, so it wouldn't have confounding by the drugs that were used in these trials. Anyway, we figure out a way to cooperate, which, by the way, was kind of tricky because it's three different pharmaceutical companies and three different powerful investigative groups, but we all get along well. And at the end of the day, figured out a way to have a common set of analyses done at each of the clinical trial coordinating centers, send those data to my group in Boston, where our biostatisticians were able to perform a basic meta-analysis of it. So what do we find? Well, first of all, we found that LDL levels and CRP levels are remarkably identical in these three very large multinational trials. So actually doing the meta-analysis turned out to be pretty easy because the cutoff values were almost the same in the trials. But to my surprise, and I'm certain to Steve's surprise and Deepak's surprise, the observation that we had seen in PROMINENT was replicated completely in the other two settings. So now I had three major contemporary clinical trials of patients taking high-dose statins, 31,245 patients followed for up to 5 years. And what we saw crystal clear was that residual inflammatory risk, which most physicians are still not measuring, was a powerful predictor of recurrent MACE. It was a very powerful predictor of cardiovascular death and all-cause mortality, but LDL cholesterol was modest at best. And so the paper raises all sorts of questions about, well, after you put your patient with atherosclerosis on high-dose statin, what should you do next? What is driving your individual patient's risk for having that second heart attack, that second stroke, and in fact driving the likelihood of dying from those events? And I got to tell you, the answer is the inflammation more than the cholesterol. And that's a sea change, and I think it's a wake-up call for the whole field.
I've had a number of discussions with people who are involved with inflammation imaging, which I hope that we can touch on a little bit later. And as they discuss it, inflammation really is a common final pathway for cardiac events with ACS. That inflammation ends up being the piece that we still have to address, as you said. Going back to the trials, and I had the opportunity to relook at all the individual trials coming into our discussion today. And the one thing I was impressed by was that none of the trials demonstrated any significant lowering of LDL cholesterol beyond the statins, except in PROVE-IT, where there was a little bit of a decrease over time, but there was no significant on-treatment effect as far as association with LDL cholesterol. So it would be somewhat expected from this trial that we wouldn't see that as well. Do you think that that was a limitation, given that other trials have shown that lower is better?
I absolutely believe lower is better. And we know that because of trials of ezetimibe, trials of PCSK9 inhibitors. Taking your LDL cholesterol down very low is better than having it not so low. That's not what's in doubt here. The issue is, however, that once you're on a high-intensity statin, yes, these lipid-lowering trials show us that we can get more risk reduction. But let's talk about how much risk reduction. The IMPROVE-IT trial for ezetimibe was only 6%. I mean, it's a pretty small additional incremental benefit for your patient. To our surprise and perhaps even a little bit of our disappointment, the PCSK9 trials, Fourier, Odyssey, our bococizumab SPIRE trials, they all showed about a 15% reduction. Now, that's not unimportant. It is important, but it's also not particularly huge. And these drugs, of course, are very expensive. So what we've struggling with is that when we add a second lipid-lowering drug on top of a high-intensity statin, the incremental benefit is getting smaller and smaller, and the incremental cost is getting larger and larger. That doesn't mean they don't work. And it's not by any means challenging the LDL hypothesis. Lower is absolutely better. The complexity of living as a cardiologist in 2023 is that we also know lower is better for reducing inflammation. And if inflammation is the stronger signal of residual risk, the challenge to all of us is, well, why is our next drug we pull off the shelf necessarily another LDL-lowering drug? Why aren't we pulling off the shelf inflammation-lowering drugs? And of course, the reason this is so complicated is that while our CANTOS trial showed in 2017 that a very interesting drug called canakinumab, a monoclonal antibody that targets interleukin-1 beta, that we could lower cardiovascular risk by the same 15 to 17% that we got from PCSK9 inhibitors, but do it in the absence of any change in ApoB or any change in LDL at all, simply by lowering interleukin-1 and interleukin-6. Now, Tom, as you know, canakinumab is not available because it was repurposed by Novartis as an oncology drug because we made another observation at the time, which was that in that same trial, the risks of developing non-small cell lung cancer were reduced by 50 or 60%. Now, that's a big deal. So the idea that interleukin inhibition will be used in oncology has become a huge issue, and that's the only reason we don't have that drug for atherosclerosis. But we do have a remarkably inexpensive drug we can use for atherosclerosis, and that's colchicine. So I think this is one of the conundrums of this paper, is that we know that when we pick a second lipid-lowering drug after a high-intensity statin, if we pick ezetimibe, 6%. If we pick a PCSK9 inhibitor, 15%. Well, there's two major trials of low-dose colchicine. Low dose, by the way, is not the dose that you're used to giving for pericarditis or that our rheumatology colleagues might give for some rare disorders. A low dose is only 0.5 milligrams once a day, no loading dose given. And two major clinical trials, the Colcott trial of patients who had relatively recent myocardial infarction and the Lodoco 2 trial of patients who had chronic atherosclerosis. That last trial, Lodoco 2, showed a 31% reduction in risk. That's twice the benefit of a PCSK9 inhibitor. And it's a very inexpensive drug. So the question, I think, challenging all of us is, it's not about, of course we want to lower the LDL, but is that the next correct step? And is it the most cost-effective step? If I'm a payer, I might say, wait a minute. If residual inflammatory risk is the problem after I've been on a high-intensity statin, and again, in that new Lancet paper, the relative risk associated with inflammation was threefold higher. Threefold higher. That's the problem. Then the question is, well, maybe I should put my patient on an inexpensive drug first that actually targets the inflammation. So there's an immediate sort of challenge to how our guidelines are written. And Tom, it's no surprise to you, I'm not a big fan of guidelines because I've my entire career, I've argued that they tend to be 20 to 25 years behind what everybody else already knows. And let's talk about guidelines for just 1 second. So colchicine is in the European guidelines. It's in the Canadian guidelines. It's in the South American guidelines. There's only one place where it's not, and it's the ACC-AHA guidelines. And I got to tell you, I'm sure it will change, but the fact that it'll be the last to change doesn't really surprise me.
The colchicine story is quite interesting in the fact that we're also paying 10 times to 20 times more than everywhere else in the world for it. I completely agree with you. Guidelines are guidelines. They're not recipes. And we need to utilize the best information that we have, which I really think that Lodoco and this Lancet paper put together in a very nice way. It's going to be very hard for people to ignore. And I'm hoping that's what part of this podcast helps to do to amplify that story.
Tom, I'm going to give you a few details about colchicine to make sure that any listeners who might be thinking about this knows a little more, because most people have not read the papers that closely. And since there's no promotion of colchicine, because there's no pharmaceutical company going to be talking about it, a couple things people need to know. The first is, even at low dose, the low dose colchicine, by the way, is 0.5. The colchicine that you're probably more familiar with is 0.6. It actually does make a difference. And that's something I'll come back to. And I think there's a hope that there will be a 0.5 introduced to the U.S. market at some point in the near future. That would help the situation. But even at the 0.5, patients with chronic kidney disease probably should not take this drug. Colchicine is renally excreted. And although patients in the trials came in with lower GFRs, I'm a very conservative physician. I feel like, okay, if someone has a GFR of maybe 50 or 55, we know that over the next 10 years, it might go down to 40 or 35. And if someone forgets they're on this drug, they could get in trouble. So I've been a little bit sort of saying, let's go with our frequent flyers. Let's go with the patients who keep coming back with more angioplasties, more bypass surgeries, more angina. We all have them in our clinic, and we already have them on aggressive lipid-lowering therapy. So this is not a substitute at all for lipid side. It's just an addition to that. The second thing that's a little odd about colchicine is its metabolism is through some pathways that I could explain in detail, but the real issue is there's a few relatively uncommon drugs that if I have a patient on chronic colchicine, and for example, if the primary care doc wants to start an antifungal, ketoconazole, as an example, you probably have to discontinue the colchicine for a week or two. So there's some rare drugs like that. And one of them, by the way, is ritonavir, which no one cared about until recently with Paxlovid. So if you're on Paxlovid and you happen to be on colchicine, you probably also want to just stop for a few days. But it's a chronic therapy. The same way we take lipid lowering long term, we're talking about taking colchicine at this low dose long term. And at that low dose, they won't get the side effects that the high dose colchicine patients routinely get.
Some of your early work, when you were looking at colchicine, you also investigated some other anti-inflammatories like methotrexate, targeting the IL-1 and IL-6 pathways. Part of that work demonstrated that those pathways then led to decrease in high sensitivity CRP. So sort of two questions here. One is, where do you think we're going to be looking at within those pathways going in the future as far as other therapies and other ways to focus in? And secondarily, and probably more importantly, should we be using some of these markers as indications of success?
Sure. So let's start with the biomarker half of that question because it is very important. Let's think about the fact that most listeners probably don't measure high sensitivity CRP at all. I mean, that's just the reality of it. Our guidelines, again, only call for the use of hs-CRP as sort of a tiebreaker if you're going to go on statins or not. Again, that's quite different than guidelines elsewhere, where it's routinely measured in all patients. I personally think it should be routinely measured in all patients for some very simple reasons. Think about this. We measure LDL in every patient. Imagine trying to treat hyperlipidemia without even measuring the LDL cholesterol. It would be laughable. Think about blood pressure. Imagine trying to tell physicians, we're going to treat blood pressure, but we're not going to actually measure it. It would be laughable. And we are in an era where we know that treating inflammation is just as important as treating blood pressure or hyperlipidemia, and yet we're not measuring it. So the first thing to do is you just have to measure it, and you have to get comfortable doing so, and you have to learn how the assay works. And the good news is it's very inexpensive. It always has been, and it should just be routine. In fact, it makes me chuckle again about guidelines. We routinely measure HDL cholesterol. Now, HDL is a very good biomarker of risk, but we don't have a single therapy that's been shown to lower risk because we raised HDL. And triglycerides, we measure triglycerides on almost everybody. And again, none of the trials have been able to link triglyceride lowering to the actual benefit of any drug. But we have lots of evidence that lowering inflammation does, and we're not measuring. So that's number one is you got to measure it to even understand the biologic principles underlying why your patient sitting in clinic with you is having all these recurrent events. Okay. Your second question, though, Tom, is really the billion-dollar question at one level and also the really important one about the future. So you're right. There's this canonical pathway that goes from something called the NLRP3 inflammasome. The inflammasome is a set of macromolecular proteins inside certain cells that recognizes certain foreign entities, one of which is crystalline structures. This is worth thinking about. It's not the uric acid circulating in your blood that causes the problem. It's the crystalline urate that is recognized by this inflammasome. It upregulates the production of certain cytokines, interleukin-1 beta and interleukin-18. Those in turn upregulate the central signaling cytokine, interleukin-6. And guess what? Your toe hurts, your joint hurts, it's painful, it's swollen, and you have this profound acute inflammatory condition that we call gout. And all the drugs we use to treat gout attack this central inflammasomal process, including, by the way, colchicine, out of interest. But there's another crystal that cardiologists spend most of their day shattering in the cath lab, and that's called the cholesterol crystal. Now, again, this is not the circulating levels of cholesterol in milligrams per deciliter. It's the actual crystalline cholesterol in the plaque. Now, when we go to the cath lab, we open that plaque, that's great. We're making the patient feel better. We're getting oxygen back to the heart. We're aborting the heart attack. These are all great things to do. And we relieve angina. But we then send all these crystals downstream because that's what we're doing. We're shattering the plaque. And those crystals upregulate this exact same inflammatory process. So inside that pathway are a whole series of biologic targets. Now, you mentioned our methotrexate trial. That was what I call a spectacular failure. And what I mean by that is it was a great idea that just didn't work. That happens a lot in medicine. But it was a really informative failure. Because when we launched the NIH-funded, what you're calling the CERT trial, the cardiovascular inflammation reduction trial, we elected to use low-dose methotrexate because it's the most commonly used drug worldwide to treat rheumatoid arthritis. And it's a very effective anti-inflammatory. We also simultaneously had launched our CANTOS trial with the interleukin-1 beta inhibitor. Well, the IL-1 beta inhibitor worked, and methotrexate did not. What we also learned in the methotrexate trial was that in marked contrast to the IL-1 trial, we had no reduction in CRP. We had no reduction in interleukin-1 or interleukin-6. And that was an eye-opener. I said, aha, inflammation is this broad-based term that covers a lot of things. What the inflammation we want to target is that central interleukin 1 to interleukin 6 to CRP pathway. And that's, by the way, where colchicine works. It's where canakinumab works. But it turned out that's not where methotrexate works. So it's actually one of those neutral studies that was actually highly informative. But I think the real question you're asking is, where are we going?
Before we jump into there, one of the things that I'm very interested in trying to identify how we're going to be working with individual patients and trying to identify whether or not the systemic markers versus more localized markers are beneficial. And one of the things that we started working with was looking at the perivascular adipose tissue and looking at fat attenuation indexing, which is a marker of inflammation within the coronary arteries. The group in Oxford identified was that when patients were on colchicine, they did see a decrease in coronary inflammation on colchicine, and they didn't see it on methotrexate, which was quite interesting. And it was from the UK Bio database. It's a very interesting and thought-provoking idea, and it really matches what you're finding clinically from the other trial work, which I think is absolutely wonderful when those things happen. Are there other markers or other ways that you are looking at these things in a more personalized way? And do you think that these serum markers versus more localized imaging markers may have a role right now in identifying patients who are at risk?
Well, today we are completely limited to use just the serum biomarkers. So the same way we measure LDL, we'll measure high sensitivity C-reactive protein. But the imaging data you're referring to is quite provocative. There are multiple different imaging modalities that are being sort of developed to help us understand if we can image this inflammation directly. And you mentioned one of them, the fat attenuation index. What they have in common is this underlying biologic principle that fat cells, adipocytes, they are a factory, a production source of all these cytokines that we're talking about. And it's within those cells that a lot of this inflammasomal activity occurs. And so perivascular fat sitting around the coronary vessels, is locally near the coronary, and people have hypothesized that maybe that's a depot for these cytokines locally. And a lot of ongoing work will help us to figure out whether these technologies work and whether they're effective.
One interesting thing working with the group in Oxford is that they actually identified for them that it was the opposite, that it was the inflammation within the coronary arteries. They did a study of patients who had biopsies after bypass. And what they ultimately found was that it was the inflammation within the coronary arteries that was then causing apoptosis within the fat cells. So there may be a difference between central adiposity and these responsive adipose tissues, especially around the coronary arteries.
What you're really summarizing is an area of exceptional controversy, actually. Some have argued that there's a bidirectional flow of this insult, and others have been less convinced. We'll find out. We'll see what this research leads us to. But I think your bigger conclusion is the undoubtedly correct one, which is that either way, we've got to target this inflammation if we're going to attack this disease. And then that, of course, is what the new data is about anyway.
Next up for you is the Zeus trial, if I can say this correctly, ziltivekimab. And one of the things I was interested in was that you've chosen to do it in patients who have renal insufficiency.
So a small company in Waltham, Massachusetts, which is about, less than 15 miles from where I am right now, was developing an interleukin 6 ligand inhibitor. So many physicians are familiar with certain IL-6 inhibitors that are used to treat, say, inflammatory bowel disease or rheumatoid arthritis or Crohn's. Most of those are interleukin 6 receptor antagonists that lower IL-6 by blocking the receptor. This particular drug, which now goes by the name ziltivekimab, as you correctly figured out how to pronounce, which is very good, I'm impressed by that, is a therapeutic monoclonal antibody that directly targets IL-6 itself, not the receptor. They were thinking about what to do with this drug, and I had a series of conversations with them and said, well, look, given what we know to be true with interleukin-1 inhibition, but given another piece of evidence from the IL-1 trial, which was that the only thing that predicted the benefit, it wasn't whether you were older or younger or had diabetes, didn't have diabetes, or had any particular clinical factor. It was entirely your response to the drug. That the people who had the most robust IL-6 inhibition after taking that IL-1 inhibitor, they had like a 36% reduction in risk. But the people who had a less robust IL-6 response to the drug really looked kind of like placebo. So that gets into your whole question about personalized medicine. Maybe we can figure out either just the people who truly benefit, or perhaps a more powerful drug that everybody would benefit. Anyway, we did a phase 2 study that goes by the name of Rescue that was published now about 2 years ago, where we showed that if you gave our patients, atherosclerotic patients, this new IL-6 inhibitor, you got a CRP reduction. That's the downstream thing we can measure. That was twice as large as what we saw in Canto. So now we're getting 85, 90% reductions in CRP instead of 30 or 40% reductions. And that's because we're really hitting IL-6 directly. Any event, Novo Nordisk, they had the foresight to say, well, look, maybe we can exploit this new biology to understand a new way to reduce atherosclerotic risk. So they in-licensed ziltivekimab, and I have the distinct pleasure of helping to design the various clinical trials that they're doing with this drug. And the first one, as you noted, is called Zeus. Forgive us for these Greek-Roman god names. We need to be a little more creative than that. But the Zeus is the ziltivekimab cardiovascular outcome study. And you're right, it's specifically in chronic kidney disease, and that's because I wanted it to be starting there. Why? Well, as I said earlier, I can't give colchicine to patients with chronic kidney disease. So it was an enormous unmet need that even if you did use colchicine, well, you can't. So that's number one. Number two is these are patients of ours with their highest vascular risk. Patients who have prior atherosclerosis and stage 3 or 4 CKD, they're not going to die from kidney disease. They're going to die from atherosclerotic events. And that's been known for a long time. And third, it's the only group where statin therapy is actually less effective. Now, we still give statins to our patients with CKD. But remember, in all the big statin trials that were done, as the GFR drops further and further and further, the drugs get less and less effective. And in dialysis, of course, the statins really have no risk reduction at all. So that's a third signal because in the setting of kidney failure, this inflammatory process is augmented. So IL-6, CRP, IL-1 are even more powerful determinants of risk in the setting of CKD. For all three of those reasons, we thought, aha, high unmet need, can't give colchicine, and statins work less. This is the perfect target for this first trial. So the good news I can give you, Tom, is that we had an investigator meeting in Milan just about, I don't know, now 2.5 weeks ago. The trial is about 45% enrolled worldwide. Ultimately, it'll have 6,200 participants. They all have atherosclerosis. They all have stage 3 or 4 CKD. They're all on high-intensity statins already. And they have what we call residual inflammatory risk. They have, by definition, a high-sensitivity CRP, despite all their good care, greater than 2 milligrams per liter. That's the definition of residual inflammatory risk. And they're being randomly allocated to 15 milligrams of ziltivekimab subcutaneously once a month compared to placebo. And the primary endpoint is hard vascular events. Can we reduce heart attack, stroke, cardiovascular death in these patients? Now, I actually co-chaired the trial with Vlado Perkovic, who some of you readers and listeners may know. He's a very prominent nephrologist in Australia. And the reason for that we have a nephrologist involved is our key secondary endpoint is can we actually slow, if not improve, kidney function? And without going into it today, because it'll be long and a little bit dull, I suspect, this entire NLRP3 inflammasomal biology is also very relevant for the kidney. And so simultaneously, we're trying to figure out, can we alter the slope of the GFR curve, if you like, by giving this drug? So that trial's up and running. What's remarkable, and I got to give Novo Nordisk great credit, is they also are seeing this bigger picture. So a second clinical trial using ziltivekimab has also been publicly launched. And this is a trial that Mark Petrie in the UK is helping to drive along with our group. This is actually in HFpEF. So it's kind of interesting to think about this. In the heart failure world, there's many different biologic principles underlying why patients develop heart failure. There's several signals that point to this inflammatory response, and there's several signals that suggest that this inflammatory response, if anything, is more likely to be a problem in HFpEF than in HFrEF. And so that clinical trial is called Hermes, and it's just launching now. And it'll, again, will take several thousand patients with HFpEF, and they're getting all the usual good therapies. And they'll get DAPA because that's the recent drug, as we know, that's been shown to be effective in that setting. But they're going to get this inflammation targeted. And then beyond that, I'm really excited because it looks like there's also going to be an acute coronary ischemia trial where drug, ziltivekimab, is likely to be started right in the cath lab at the time of opening up the artery and then given for 12 months. And so the point here is, between these three studies, we'll really see a broad spectrum of patients treated with this targeted IL-6 inhibitor. There's no guarantee it's going to work. This is an experiment. So we should know this information within the next 2 or 3 years and have to figure out, is this another way of taking our patients towards a healthier long-term life?
One of the problems that we have in looking at or the utilization of high sensitivity CRP is this question of sensitivity and specificity. How would you identify that? These are the patients that are truly at high risk for coronary disease versus more of a systemic inflammatory response. Or do you think it's important?
So Tom, it's interesting. This is a kind of a question that was asked and answered some time ago, but I think that in the clinical realm, people are still confused by. So let's take that carefully. Most of us believe at this point that it's actually a moot point, that inflammation from any cause, is perceived by the vascular endothelium as an elevated risk to itself. That, in other words, the endothelium is responding to this inflammatory insult. So why do we know that today? Well, there are 37 different autoimmune diseases, ranging from ankylosing spondylitis to lupus to psoriasis to inflammatory bowel disease, Addison's disease, you name it. Psoriasis is another one, by the way. Every single one of those is associated with accelerated atherosclerotic risk. We now know that. We didn't know that 15 years ago. So it turns out that any disorder that is associated with this inflammatory process increases cardiovascular risk. So we don't worry about where is the inflammation coming from anymore, because we know that if we measure it, my patient's at increased risk. So I think this kind of takes that issue off the table and simply says, look, it's just like, we don't ask, why is your LDL elevated? We just say it's elevated and we got to do something about it. So I think that's made this much easier. Now, that being said, unlike, say, measuring blood pressure, the CRP levels can vary. That is true. And so we generally say, look, if you get a value that's very high, and as you suggested, say something greater than 10 milligrams per liter, my suggestion is remeasure it again, maybe in a week or two. Just make sure the patient wasn't in the midst of an acute phase response. Maybe they had a bad infection you didn't notice. The truth is, though, the vast majority of people whose value is 10, it's going to come back 10 again because it's real. And so once you have a high value, I would just go ahead and say, okay, they have residual inflammatory risk, and we're going to go ahead and treat. It's actually interesting. We did a very large sub-study within our Jupiter trial many years ago where we looked at the variability in LDL cholesterol and the variability in CRP. They were the same. And that's because people forget that LDL is also an acute phase reactant. That's why we're always taught in residency, don't measure LDL at the time of a coronary event because it goes up and down. Anyway, I think this is really an issue of the past. People now understand that with these high sensitivity assays, we're getting very valuable data. I do want to, Tom, though, make sure we talk about some primary prevention issues here. Sometimes I worry that we focus a little bit too much on the drugs. The drugs are very powerful, no doubt about it. And our new data that we began your podcast on are really important to rethink and reshape how we as physicians think about what drug are we going to give next. But I do want to make sure we talk about some basics. Inflammation is driven by the same things that drive poor living. So diet, exercise, smoking cessation, they all lower hs-CRP. They all lower cardiovascular event rates. Remember years ago, the Predimed trial where people in Spain on background of a Mediterranean diet were simply randomly allocated to boxes of nuts, literally boxes of nuts and or bottles of extra virgin olive oil, and they had major reductions in cardiovascular events. Well, those two interventions weren't chosen randomly. They both happened to also lower inflammation. So when you read about anti-inflammatory diets, it's actually real. When you read about exercise being an anti-inflammatory, it's actually real. I think this is really important because as a preventive cardiologist, I sometimes feel like we don't give adequate time to our patients to sort of reinforce the good behaviors that we want them to do. And so I want to make sure we had talked about that because at the end of the day, the drugs really matter. If you have atherosclerotic disease, talk to your physician about these agents. But if you don't have atherosclerotic disease, but you're at risk, well, there's other things you can do that are really lifestyle-oriented that I think are, in the long run, the best way to deal with this.
Is there a specific dietary prescription that you're giving to your patients who have elevated high-sensitivity CRP or just trying to decrease cardiovascular risk?
I have a lot of friends who are nutritional epidemiologists, and what I've learned from that general literature is it's really complicated and really hard to figure out the wheat from the chaff. So I tell my patients, I say, look, I'm not a proponent of any particular dietary structure. I am a proponent of generally eating well, generally eating green leafy vegetables, generally eating whole grains if you can, and generally avoiding processed foods. I think those are the relatively simple messages that seem to resonate with my patients. And so, if it comes wrapped in plastic, don't buy that. And if it comes off the shelf and it looks like something you might see on a farm, buy that. That's kind of the way I deal with this, because beyond that, to me, it gets very complicated and highly controversial, as you're well aware. I also want my patients to be happy. If someone wants to be on a vegan diet, great, but I'm not going to push it on them. They have to decide within their own social structure and their own family structure what might work best for them. All that being said, it's also true that there's some pretty good data that vegetarian diets, vegan diets, very low in animal fat, do reduce this inflammatory process even more. And certainly the people who, for cultural reasons or medical reasons, abide by them seem to do better. But I've learned not to wade into the bigger issues about which diet because I have no idea.
We recommend the vegan diet only because it's easy for them to find information on it and then tell them, you don't have to be vegans.
Right. I'll tell you something else, Tom. I tell all my patients to cheat, by the way. Once or twice, that juicy hamburger is pretty darn good, but maybe the 99% of the time, eat well, something like that.
The second question we had on that was about pharmacotherapy, though, on patients who have these elevated risk profiles, because I do think that we need to include hs-CRP in our overall risk profile. So if you have someone who has a, say, borderline LDL cholesterol of 110, and they have an elevated hs-CRP and perhaps a family history, would you start them on a statin?
We have to distinguish here between primary prevention, which is where I think you're going, from secondary prevention. So we're talking here about patients who have risk factors for atherosclerotic disease but have not suffered a first heart attack or stroke, right? In 2008, we published the results of a clinical trial called Jupiter that started in the year 2000. So 23 years ago, we said there's something fundamentally wrong with the guidelines, guys, and we got to really wake up and address this. So we designed a clinical trial where the entry criterion was the LDL cholesterol would never qualify you for a statin under any guideline at the time, which, by the way, just to tell you how guidelines work, back then in 2000, our guidelines said if your LDL cholesterol is greater than 160, be very aggressive and take it all the way down to 130. That was the guideline. And we said, okay. So we randomized 17,000 patients on a global basis where the average LDL cholesterol untreated primary prevention at baseline was only 100. So nobody would ever get treated. But every single one of those patients in Jupiter had a high sensitivity CRP greater than 2 milligrams per liter. And the Jupiter trial, which gave rosuvastatin at 20 milligrams, by the way, there's another thing. We decided to give high intensity statin 23 years ago. So anybody who's not, I don't get it. It's like, where you been? Okay. So anyway, what did the Jupiter trial show? A 44% reduction in major adverse cardiovascular events, a 63% reduction in myocardial infarction, 52% reduction in stroke, and it's the only statin trial in primary prevention ever to show a reduction in all-cause mortality, which was 20%. Now I want to repeat that for a second. 40, 50, 60% reductions in vascular. We get excited today when we hear something about 5 or 10%. So the answer to your question, Tom, is absolutely. If there's a patient in primary prevention who has an elevated CRP, irrespective of their LDL level, they should be considered eligible for statin therapy. Now, again, I want them to eat well, I want them to diet, I want them to exercise, but in my clinic, they're going to get a statin. And again, it's astonishing to me with that kind of data. By the way, there were 7 zeros in the p-value, okay? With that kind of data, our guidelines still don't say that these patients should be on a statin, but they absolutely should be. We have this disconnect, which simply is, I think, due to the historic fact that physicians just haven't wrapped their heads around the other half of this disease, which is the inflammatory component.
I also think there's a little bit of a hesitancy on the patient side with statins and initiation of statins, and they have to be educated so that they can be our partners in this.
Well, actually, Tom, it's a great point. So in your clinic, like mine, we're all referred patients who are quote unquote statin intolerant. I have to say 9 out of 10 of those, it's rather easy to get them on a statin in my experience. And I'll something like rosuvastatin 5 milligrams every other day is an extraordinarily good LDL CRP lowering regimen, and almost everybody tolerates it. So I think a lot of this is internet driven, water cooler driven. Oh, I took my statin and I went to the gym. And guess what? My muscles ache because I went to the gym and I'm blaming the statin. So that's number one. However, we all also recognize there are patients, small number, but they're real, who truly do get myositis from statin therapy. I was tickled pink to see at the ACC meeting that the bempedoic acid data, the CLEAR Outcomes trial, came out. And if you read that New England Journal paper, what tickled me pink was that in the main part of the paper, they give the LDL lowering and the CRP lowering of the drug right next to each other. So it's very clear that the folks behind the bempedoic acid trial have understood that you want to promote this idea that here's a drug like statins, by the way, that both lowers LDL and lowers CRP. And of course, the bempedoic acid trial was done on patients who were statin intolerant. So there's another way to go if you have true statin intolerance.
Well, this has been wonderful. And if there's any way that I can get you back again, because there's so many other questions that I would like to ask you. You've been at the forefront of cardiovascular research for decades. This has been a wonderful experience for me, and I hope that you enjoyed this as well.
It's my pleasure, Tom.
Thank you.